Hi everyone, and welcome to this presentation on the LGBTQ plus community health profiles and the engagement work that we're doing around that. So for this webinar, I'll be discussing our 4 LGBTQ plus community health profiles and the engagement work that we're doing around it. I'm conscious of not wanting to spend too much time just listing off the health inequalities that are experienced by the community, as those are all covered in detail within the profiles themselves. So I'm going to focus more on what the profiles are as resources, how they can be used, and how we plan on engaging with the LGBTQ plus community going forward in addressing health inequalities. So I'll start with a bit of housekeeping, go through the profiles and the inequalities in them, and then talk about the engagement activities, and then end with a bit of a Q&A. So yeah, just as housekeeping, if you could keep your mics muted, keep your cameras off if you want to not be in the recording, and just to save any sort of bandwidth. The slides will be uploaded and shared after on YouTube. And if you do have any questions, pop them in the chat, but we'll do a Q&A session at the end as well. So also, there's a safe places approach in this webinar and across the conference. So it's focusing on allowing everybody to learn, share, and grow in a way that's respectful, empathetic, caring, supportive, and inclusive. Okay, cool. So to get started, what are the community health profiles? Well, they're desktop pieces of research which summarize the published evidence, the grey literature, and population survey data on different communities of identity in Birmingham. They provide a snapshot of the physical and mental health of the specific community, as well as the lifestyle, behavioural, and wider determinants of this. Each profile looks at the health inequalities throughout the life course and the information that's presented in these themes according to the key priority areas that are identified in the health and wellbeing strategy. So that's getting the best start in life, mental wellness and balance, healthy and affordable food, active at every age and ability, working and learning well, protect to detect, aging and dying well, green and sustainable future on the side there. In addition to the profiles as well, we've also got a range of census infographics that are shared alongside them. Somebody in the team can probably put the link to the community health profiles in the chat, please. Okay, cool. And yeah, within each of the themes, they're also split into subtopics. So the protect and detect theme looks at like cancer screenings, vaccination programs, sexual health, that sort of thing. So in terms of the aims of the community health profiles, they were developed because we want to move away from the sort of traditional acronyms of AIM, and in this case, LGBTQ+, which kind of homogenizes communities together and overlooks the differences that there actually are between the health outcomes within these groups. So the community health profiles look to bring the data into one place and ensure that it's accessible. We want to ensure access to health and wellbeing data in a way that's easy to understand and it all sits within one convenient report. And kind of through that, we hope that it's going to enable better decision making around data in policy, strategy, and programs. By setting out the differences in needs between the groups, we hope that the profiles will equip local authorities and wider healthcare systems to make decisions that are going to develop better policies and services that are culturally relevant and appropriate for all citizens, so that we can effectively address health inequalities. So in terms of the methodology behind the community health profiles, I'm not going to go into lots of detail on this because the communities team have just developed a video that does an overview of all of the profiles and what's involved in them. Thanks Jordan. Jordan's just put it in the chat. Yeah, that covers the methodology in depth, and that'll be shared widely as well. But in short, the profiles that were written internally in 2023 That's the gay men and men who have sex with men and bisexual profiles. We started those with an Ovid search that's conducted a search of all academic databases with specific search criteria. So stuff to do with like the time that it was the date that it was published, in what area, that's in what language, that sort of thing. When we did that search, there was consideration of the quality of the studies and the data in the results, and we had a set of quality criteria that we used to do that. For the lesbian and the trans profiles, these were written externally by commissioned organisations in 2022, and the search strategy for those is slightly different, but on the whole fairly similar. And the search strategy involved and the methodology involved are explained within each of the profiles as well. So for some of the communities, the academic literature on health and well-being is very limited. So the search was expanded to include relevant grey literature as well, such as reports by Stonewall and the LGBT Foundation. The profiles also make, or at least the gay and the bisexual profiles makes like significant use of the 2021 census data, as well as data from Health Survey for England, GP patient surveys, Fingertips, Department for Education, and other resources like that. There's lots of limitations in using this data for understanding the inequalities for the LGBTQ plus community, but I'll go through those in a sec. Okay, so the limitations of some of the studies and data for the LGBTQ plus community are pretty significant. So there's lots of issues with the availability and the quality of the data, which limits the capacity to understand the size of the community, but also to identify and address the health inequalities that they experience. And I'll discuss some of those issues now. So firstly, data is often aggregated based on gender or LGBTQ plus status, meaning that different demographics within the community are grouped together and can't be differentiated. And that causes significant issues for understanding the differences between those groups. So for example, the 2021 census aggregates gay and lesbian together within one category, without distinguishing between them based on gender identity. So, and in some data, bisexual men are often grouped with gay men. And that kind of erases those individual groups within health data. So we can't understand specific health needs that they might have. And similarly, methods of recording sexual orientation and gender identity can differ between studies and between organizations, which reduces the ability to effectively compare data sets. Also LGBTQ plus health data often isn't adjusted for other variables such as age, which can significantly skew data as well. Secondly, mistrust and fear of discrimination means that people may choose not to disclose their LGBTQ plus identity. So there's issues with underreporting, meaning that data is generally inaccurate and kind of, sort of doesn't show the full size of the community and the experiences of them. Thirdly, data often doesn't exist at a Birmingham level, so national level data has to be relied upon. And even where data does exist, such as the 2021 census, multivariate data can't be accessed at a local level, usually to protect the risk of identification. For example, it's not possible to access data for Birmingham level that looks at sexual orientation by disability by another variable, such as employment status or general health. And one of the big issues with that is that it prevents consideration of intersectionality in understanding health inequalities and how those things can compound. So all of these issues make a strong case for improving data collection for the LGBTQ plus community within Birmingham, particularly regarding health and its wider determinants. But it's also essential that the community are consulted in the process of improving this data so that some of these issues I've just discussed aren't continued. Okay, so how do we want people to actually use the community health profiles? And there's lots of ways you can apply them and engage with the community health profiles in your work. So firstly, we want to use them to increase cultural intelligence. We encourage everybody to read the profiles and build their knowledge and understanding of the community and the health inequalities that they experience. We want people to share them widely with their colleagues, their wider organisation, and their networks to encourage them to do the same as well. And the information should be used to provide culturally relevant healthcare and other services in the community. But we also recognise that the profiles aren't perfect and we are planning on doing refreshes of them. So we want to encourage people to provide us with feedback. Somebody from the team can probably put a link to share feedback with us, or you can email us at our email that somebody from the team will put in. So in terms of what we want feedback on, if you feel there's inappropriate language that's used or a key community health need or important report isn't included, then please let us know via email and we'll update that during our next refresh. We also want the profiles, and it's kind of one of the core purposes of them, we want them to be used as evidence. We want people to reference them, use the data and evidence that's shared within them to inform and support new health interventions and policies with the LGBTQ plus community. We want people to use them to justify further primary data collection to fill the gaps that are identified within the profiles. And we're also keen for especially community organisations to use the profiles as evidence in funding bids. The profiles can also be used for collaborating with communities. So we encourage health services to use them as a tool for engagement and to support them in advocating for changes to address health inequalities. Okay, so now I am going to talk a bit about the different health inequalities that are discussed in the profiles. Some of these statistics are pretty upsetting, so please do feel free to leave and join back in about 10, 12 minutes if you'd like. But yeah, with that, I will discuss some of these. I won't go into detail on the explanations for these inequalities or the sources that they're taken from, because this information is discussed in a lot more detail in the profiles themselves. And it should be noted as well that the statistics that I give in this presentation and in the profile might not be the most current, but the profiles will be refreshed. So in terms of mental health, that's one of the major health inequalities identified within the lesbian community. So 38% higher rates of poor mental health, including anxiety and depression in lesbians compared to heterosexual women. The rate of self-harm among lesbian women is double that of heterosexual women. There's also significant issues with substance misuse, including smoking and alcohol consumption. So 79% reported having ever used drugs compared to heterosexual women, which was 61%. And 45% of lesbians reported being smokers compared to 36% of straight women. In terms of alcohol intake among lesbians within the West Midlands, there was a few different studies, but 25 to 37%, which is higher than the regional average, for adults, which was 7%. There's also a lot of studies looking at issues around eating disorders within lesbian and bisexual women. So around 1 in 5 lesbian and bisexual women have an eating disorder, which compares to 1 in 20 heterosexual women. And 49% of lesbian women are at a healthy body weight compared to 54% of heterosexual women. Lesbian women were also 1.5 to 2 times more likely to be obese across multiple different studies. One of the major health inequalities that have been identified in different studies is around cervical cancer screenings. So lesbian women were less likely to attend pap smears, despite having similar rates of cervical abnormalities. Within the West Midlands, between 48 and 55% of lesbian women regularly attended cervical cancer screenings, and that's compared to 81% of straight women. There was also a few different studies that looked at experiences of lesbian women in older age. So lesbians with dementia were shown to experience a double stigma of their sexuality and their dementia. And it is found that many residential care settings feature heteronormative communities that don't really understand the experiences of lesbians in older age. Also, in terms of experiences of healthcare more widely, lesbians were more likely to report having no trust in their doctor and less likely to have attended the GP in the last 3 months. Okay, so moving on. Now we'll look at some of the health inequalities experienced by the gay community. A lot of them are quite similar across the different communities within the LGBTQ plus community as well. So in a 2016 study, 21% of gay men and men who have sex with men reported being depressed, 17% were anxious, 7% had self-harmed, and 3% had attempted suicide within the last 12 months. Although I should say there's quite a lot of studies on the mental health of gay men, and statistics do vary quite a lot on that. But the general consensus is that the mental health of gay men is worse than straight men. In terms of discrimination, a higher percentage of LGBT boys, that's 57%, reported being bullied in school compared to 35% of LGBT girls. However, 41% of LGBT boys did not report that bullying to anybody. And according to a 2018 report by Stonewall, 19% of gay men experienced a hate crime or incident based on their sexual orientation in the last 12 months. So there's also significant issues with substance misuse among gay men. 30% of gay men in one study engaged in hazardous drinking, compared to 18% of heterosexual men. 21% of gay men are current smokers, compared to 16% of heterosexual men. And gay men were 3 times more likely to report illicit drug use than straight men. Chemsex is also a big issue in this community, and that's been covered in a previous webinar that was during the Pride Wow Summit. So I'd encourage everybody to go and watch that as well for more information. There's also greater experiences of domestic violence among gay men. So in a 2018 crime survey, 12% of gay men experienced domestic violence compared to 4% of straight men. In terms of screening and sexual health, 7,000 gay and bisexual and other men who have sex with men in 100,000 received a new STI diagnosis in 2021, and that was compared to 300 in 100,000 heterosexual men. And I should say, some of the statistics I'm giving highlight the issue that I mentioned earlier with data where gay, bisexual men and men who have sex with men are aggregated together, which makes it hard to distinguish between them or impossible to distinguish between them in the data. So to understand the actual differences between those communities. But moving on, in terms of physical activity, most studies showed there weren't significant differences in physical activity between gay men and straight men. However, they did highlight barriers to participation in certain physical activities, such as team sports. 70% of gay men agreed that homophobia is more common in team sporting environments than in general society, and that was a barrier for them taking part. Similarly to experiences of lesbians, there's also more studies coming out looking at experiences of discrimination in older age for gay men. So in a study by Stonewall, 47% of lesbian, gay and bisexual people aged 55 plus were not comfortable disclosing their sexual identity to care home staff. And 76% of LGBT people were not confident they would be treated with respect in care homes. Looking at the intersectionality of that, there's a dual impact of ageism and homophobia that influences heightened levels of loneliness and isolation among gay men, particularly in older age. And sort of relating to that, there's a barrier to good end of life care for gay men because they're unable to list, or historically, they're unable to list their family of choice or their partner and give them power of attorney in end of life decisions when making decisions with relevant authorities. So now moving on to some of the health inequalities experienced by bisexual people. And I should say that generally there's a lack of health data looking at the experiences of bisexual men and women, less so than lesbians and gay men. And a lot of that is because bisexuals tend to get aggregated with either gay men or lesbians and gay women. But again, there's similar issues around poor mental health and suicide rates. So in 2023, 40% of bisexual respondents listed a mental health condition, compared with 12% of heterosexual and 27% of gay or lesbian respondents, which is quite interesting that the experiences of bisexual people in terms of health inequalities and mental health, it was higher than gay or lesbian respondents. Also 2.1 times, there were 2.1 times higher chances of bisexual people committing suicide. I've phrased that wrong. 2.1 times higher odds of future suicide risk among bisexual young people aged 16 to 25 compared to lesbian and gay younger people. And bisexual people were more likely to experience loneliness and isolation compared to straight people. Bisexual people can also experience discrimination from both straight people and other LGBTQ plus people, particularly in the form of bi erasure, which is essentially being misidentified as being actually straight or actually gay from either of those communities, and that in itself can contribute towards loneliness. Bisexuals also had a higher use of illicit drugs in one study in the previous year compared to heterosexuals and compared to lesbian and gay men. So it was 37% of bisexuals reported illicit drug use in the previous year compared to 11% of heterosexuals and 25% of lesbians and gay men. There were also higher experiences of domestic violence among bisexual women, that's 25%, compared to heterosexual women, which was 7%. In terms of healthy eating and obesity, some data suggests that bisexuals were less likely to be overweight or obese than straight people. However, bisexuals are more likely to engage in disordered eating than straight people. And I've already mentioned the statistic around sexual health. 7,000 gay, bisexual men and other men who have sex with men in 100,000 received a new STI diagnosis in 2021. And that's compared to 300 in 100,000 heterosexual men. Finally, I'll talk about some trans health inequalities. So again, and this is consistent across LGBTQ plus groups, there were issues with mental health and suicide. So 70% of trans and non-binary adults have experienced depression or anxiety in the last 12 months compared to heterosexual people. That's in one study. But only 36% had actually accessed mental health services in the last 12 months as well. Young trans people aged 16 to 25 are at a significantly higher risk of suicide, and 25% had attempted suicide in the last year. There's also issues with substance misuse among trans people. 62% of trans people reported alcohol dependency, and that compares to 1.6%. Excuse me. That compares to 1.6% among the resident population in Birmingham and 1.4% among the general population in England. In terms of discrimination, 93% of trans survey respondents in one study said they'd experienced transphobia in the last 12 months. And there's also been a 789% increase in transphobic hate crimes from 2010 to 2021. One of the issues that contributes to this poor mental health is that there's very limited access to trans-specific healthcare and gender-affirming care, which for people experiencing gender dysphoria is detrimental to your health. So 80% of trans people reported finding gender identity clinics difficult to access, and 30% of trans people in the West Midlands said their GP did not know how to refer to gender identity clinics. Whilst some of this data might have changed because it's changing constantly, wait times for first appointments in gender identity clinics can be over 4 years long. There's also many barriers to trans people accessing healthcare generally, including a lack of understanding about trans-specific health, unknowledgeable or unsupportive GPs, and trans-specific health needs being ignored. But also many trans people are reluctant to use GPs and health services because of previous negative experiences and fears of discrimination. There's also, similar to lesbian women, there's issues with and barriers to cervical cancer screenings. So 58% of eligible trans people registered female at birth had undergone cervical screening. And 17% of trans people had accessed sexual health services in the preceding 12 months, compared with 29% of cisgender LGBT people. There's also issues with lower rates of physical activity. So 52% of trans people achieve the recommended weekly levels of physical activity. That's compared to 60% of cis women and 62% of cis men. Trans people also experience inequalities and discrimination outside of healthcare settings as well. So there's significant inequalities in the wider determinants of health. So 35% of trans people in the UK had completed a higher level qualification, so higher education. That's compared to 51% of cis LGBT population. And that highlights health inequalities within the LGBTQ plus community. And in that highlights the importance of not aggregating that group and treating them as a homogenous community. Similarly, 25% of trans people in the UK have been homeless at some point in their lives. That's compared to 16% of cis LGBT people. And in Birmingham, 26% of trans people are unemployed, compared to 14% of cisgender LGBT people. Yeah, and as I said, that shows quite significant differences even within the LGBTQ plus community. So I realise I've just spent quite a long time reeling off health inequalities. So I'm going to start doing that now and move on to discussing some of the work. Oh, sorry, wrong. 2 to 3 more minutes discussing health inequalities, and then I'll move on to talking about our engagement partners. So it's essential that we understand the role of intersectionality in health inequalities experienced by LGBTQ plus people, and don't treat the community as a homogenous group when developing health policies, services, and programs. For example, 33% of trans people self-reported having a disability. That's compared to 14% of cisgender LGBT people and 19% of working age adults in the general population. And 24% of trans people are estimated to have autism spectrum disorder versus 5% of cisgender people. It's essential that we recognise that health inequalities can compound. So living with a disability as a trans person can exacerbate existing inequalities related to employment, education, physical activity, mental health, and access to services. And we also have multiple community health profiles that look at the health inequalities experienced by people with disabilities. And I'd encourage everybody to look at those as well. It's important to understand the intersectionality between those groups. But we should consider how we can make LGBTQ plus spaces accessible to people with disabilities as well, because often they aren't. Furthermore, the intersections between being LGBTQ plus as well as an asylum seeker or from a minority ethnic group can lead to compounding of minority stress that has significant impacts on health, particularly mental health. So for example, many LGBTQ plus asylum seekers can experience exclusion both from their home country and communities around that, including their families, but might also experience isolation from the LGBTQ plus community in the home country. So it's this kind of compounding isolation where you feel like you don't fit into either group. But yeah, as I say, generally it's important that we consider how for LGBTQ plus people, people are multifaceted and they don't just have one identity that determines their experiences, and we have to understand how those cross over. Okay. One sec, I'm just going to have a drink. Okay. Now I'm going to stop talking about health inequalities and talk a little bit about what we've done to engage with communities off the back of the community health profiles, and also talk a little bit about what we're planning on doing in the future. So following the launch of the first round of community health profiles, the communities team commissioned a range of community engagement partners to disseminate the community health profiles, to engage with the communities, and to deliver health interventions that were informed by the inequalities within the profiles. So in 2022, we partnered with the Birmingham LGBT Centre for 1 year as our trans and lesbian engagement partner. For the lesbian engagement work, the first intervention was the delivery of three-hour-long training sessions for GPs and health professionals about the health inequalities that were discussed within the profile. And it was designed to improve the cultural competence of health professionals and accessibility and delivery of primary care. The second intervention was the delivery of 6 one-hour-long dance sessions led by a local drag queen and dance tutor. And those were designed specifically to address issues around physical activity and obesity among lesbian people, which was identified within the community health profile. The community health profiles were also condensed into more accessible slides and social media comms and were shared widely. There's also we also did a range of focus groups that were delivered jointly between the lesbian and trans engagement partners. So for the trans engagement partner activities, the first one was a GP symposium event. And the purpose of this was to raise awareness among GPs on the trans health inequalities and experiences of gender affirming care and wider health services. So this involved a few different presentations. The first presentation was by Dr. James Barrett, who was the lead clinician at the Tavistock and Portman NHS Trust Gender Identity Clinic. And he discussed the experiences of GP services and gender identity clinics among trans people. And the second presentation was from Dr. Rebecca Stevens, who was a GP at the Bridge Clinic, and they discussed alternative access to gender affirming care. After the activities, participants received a resource pack that had key information covering different event topics, links to information regarding changes to NHS records and routine screening for trans patients, as well as links to training courses on trans healthcare for GPs, further reading on key trans healthcare topics, and a link to trans community health profile in order to disseminate the information within that. So the second intervention, which was a joint intervention with the lesbian community and trans community, was a series of focus groups about how to improve breast and cervical cancer screening campaigns to make them more inclusive. So within those focus groups, there was a lot of discussion about the language that's used within those campaigns. For example, there was discussion about how the word breast could be exclusionary for trans men who either would be experiencing gender dysphoria or had undergone top surgery. So the feedback was then used from these focus groups to develop a series of posters that were promoting cancer screening, but in an inclusive way. And these were put up in bars and restaurants and clubs around the gay village in Birmingham. These focus groups generally highlighted the importance of engaging with the LGBTQ plus community in developing more inclusive health campaigns and how this can help improve health outcomes such as uptake of screening. So that's some of the engagement work that we have done already off the back of the community health profiles. I'm now going to talk a little bit about the work that we plan on doing for the next few years. So over the next 2 to 3 years, the communities team are going to be commissioning and working with a series of deep engagement partners. Within that, there's going to be 8 available contracts, no, not 8, 18 available contracts covering 18 different communities of identity over 13 different lots. So that includes ethnicity, religion and faith, LGBTQ plus communities, and people with disabilities. So the engagement partners will also be supported by a commissioned academic partner who will support them with the development of evaluation, metrics, research methods, that sort of thing. And these tenders are going to be launched in early March. So please do keep an eye out for those. And they'll be shared widely in the next few weeks. The LGBTQ plus tender is split into 2 different lots of funding. So one is based on sexual orientation with the LGBT plus community, and that must have specific interventions for each of those individual groups. And the other lot is based on gender identity and is working with the trans plus community as well. The engagement partners generally are going to focus on improving public health knowledge via focus groups, which will be led according to public health priorities. They'll also focus on co-creating health interventions with the communities to tackle health inequalities and integrating the work of the engagement partner within council systems. I'll talk a little bit more about that now as well. So yeah, to expand on that, the objectives of the engagement partners are to increase awareness within the communities and more widely of the health inequalities within that community and fill gaps in data and research. We also want to improve community health literacy, enhance the capability of the community to have collective control over the programs and health policies that are delivered to address their health inequalities. We recognize that it's important that the LGBTQ plus community have a say in policies and programs that are intended to improve their health. So yeah, we wanted to bring a community voice, seldom heard voices, to strategy and policy development spaces. That is focused on getting people from the community in the same room as people that are making the decisions about health policy and strategy in Birmingham and the West Midlands more widely, so that those policies can be developed effectively. We also want to utilise existing community strengths and capabilities to come up with new solutions for improving the health of communities. In terms of what the Deep Engagement Partner activity is actually going to involve, there will be 4 focus groups per year with the communities involved. So there'll be 4 trans focus groups and 4 LGBT plus community focus groups. And they'll be led and informed by public health priorities and the needs that are identified within the community health profiles, particularly around filling the gaps in the data. So based on the health inequalities discussed, we might have something around mental health, something around substance misuse, loads of different options there. There's also, we want people from the community to attend 5 different council forums per year. So, for example, we have the Creating a City Without Inequalities Forum, or the Creating a Mentally Healthy City Forum. They'll also be asked to disseminate public health messaging within the community through a range of different channels, and deliver 1 major public health intervention to address health inequalities per year that is co-designed with the community and based on the inequalities identified within the community health profiles. So again, that could be something to do with substance misuse, mental health, physical activity. They'll also deliver 4 different training sessions for healthcare professionals per year. And within all of that, we kind of want to encourage all of the different partners to collaborate with each other, as well as other community organisations, so that they can effectively deliver these outputs in a way that considers intersectionality. So I mentioned the intersectionality between disability and the LGBTQ plus community. I think it's going to be important in this deep engagement partner work for our disability engagement partners and our LGBTQ plus engagement partners to work closely together. And the academic partner that we commission will provide support around training on focus groups, evaluation, research, that sort of thing. Okay, that is the end of the presentation. There's a range of links here to different things that I've discussed, but I think most of them are going to be in the chat. Yeah, links to profiles, overview video, that sort of thing. And here is a QR code for the feedback form for the, what's this feedback form for, Bradley? For the the summit as a whole.
A bit of both. So yeah, the top right QR code, and Dawn will put the links into the chat as well, will help. Will be the evaluation form for the session today that Alex has hosted, and also comments if you have any comments on the wider Pride Summit. And it is really important to, if you can take the time to do the evaluation form, just so we can evidence why sessions like this are so important in sharing these information. And then the bottom left is to our Eventbrite collection, so you can sign up to the last few events in the month.
The next one is in 8 minutes, so
yeah.
you go along to that. There's the next session is going to discuss inclusion health, but we'll talk a bit about the profiles as well, but with a bit more of a focus on intersectionality and like the crossover with communities of experience as well. So I'd encourage everybody to go along to that. Yeah,
brilliant. And also
I do have time for questions as well.
Yeah, I'd just say encourage people to sign up to the community health profile sessions, particularly, I mean, just because it's LGBT History Month. Sign up to the bisexual session that's on Thursday, on the last day of LGBT History Month, but also the Gay and Men Who Have Sex with Men session that is on the 4th of March.
Next Monday, yeah, I think it is.
Mm.
Yeah. Oh, I'm glad you remembered that. I forgot to mention it. Yeah. please do go along to both of those, because I skimmed over the health inequalities quite a lot, but they will go into a lot more detail about bisexual and gay men inequalities and kind of the work that we're doing around that as well. Does anybody have any questions for like the next 5 minutes? Was there any in the chat at all?
No, there isn't any in the chat so far.
Lovely.
I mean, just while people are thinking of questions, I just want to flag that what the community team has done with the community health profiles is exceptional. And working with a lot of the commissioners, some of the health care services, some of the mental health care services and the social work area, hearing how people have used these community health profiles to inform their actions, to justify why they're working in areas, because a lot of the time it's been, well, where's the data set? It's not all in one place. And actually, these community health profiles have brought together what's often been a difficult task, particularly in the LGBT space. So it's a fantastic start, and then seeing the next steps of your project and the deep partnership work that you're going to be doing is exciting. So I hope people keep an eye out for them opportunities as they come up.
Yeah, definitely. We really want to. So I didn't say, but yeah, the deep engagement stuff will be over like the next 2 to 3 years. So we really want to use that like long period of time to make a kind of a consistent effort to address health inequalities within the community, as opposed to sort of more short-term projects. And we're really going to emphasize getting people from the community in the same space as people that are making policy and strategy decisions. Hopefully that can have some impact and address the inequalities discussed. I don't think there's any more questions. And if people do have any questions that they can't think of at the moment, do just drop us an email as well. I think somebody's put it in the chat and we can discuss it more.
Brilliant. It definitely is in the chat, but the community team have a lovely and simple email address compared to a lot of the council ones, which is communities team, all one word, at birmingham.gov.uk. And that's communities, COMMUNITIES, community team at birmingham.gov.uk. Or you can email us at lgbt@birmingham.gov.uk, and I will link you in to Alex and the team